Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here today with my most excitable and occasionally devious podcast host.
Devious?
Dr. J. Calvert. How are you?
I'm good. I
think actually you just described yourself as dastardly.
So.
That was the word.
I think it was, some of the like we were just talking a little bit about some of the pranks that we had to pull on our friends in college, and some of them were really funny and not appreciated.
And not appreciated.
Not appreciated, but very funny.
And probably couldn't be done today, but funny nonetheless.
Oh, no, they could be. You just have to pay the price. That's all.
But anyways, today, kind of a big topic, a little bit of a rambling topic, but it's coming up because we had a very loyal listener actually reach out, and she had some questions about tummy tucks. And we do a lot of tummy tucks here. That's sort of what we're known for. And her question was very specific, and I don't know that we've addressed this specifically. So a little bit of backstory that she's provided for us is that she's a mother, she's had a couple of children, and she has a fairly prominent rectus diastasis. So this is when you don't have a true...
Rectus?
Oh, here we go.
Damn near killed us.
Okay.
Had to do it.
I know, it was coming.
But you have to say, what is a rectus diastasis?
What is a rectus diastasis? So your abdominal wall muscles, your six-pack muscles, they're supposed to sit right next to each other in close approximation.
I haven't seen mine in years.
Some people don't, ever. But during pregnancy or weight gain, weight loss, those muscles can separate. And if they completely separate and tear the lining between them, that's called a hernia. The intestines can come through that opening, and it has to be surgically repaired. If that lining, it's called the fascia, which is a thin covering over the muscles, if that's still intact and keeping all the abdominal wall contents in place, but just the muscle bellies, the actual fibers, the muscles themselves are separated, that's called a rectus diastasis. And it's very common in women that have had kids, and sometimes it can be very prominent, particularly in women that are rather narrow-hipped, narrow-boned, small, and then they have a child, even if the child's large. Sometimes these women can't expand horizontally. Their baby pushes straight out in front backward space, and that's when the rectus diastasis can really become prominent. And these women can look like they're 6 months pregnant with triplets. Well, they're not. It's just their muscles are so badly separated. So that's sort of the story that this particular listener was saying. And so she has a complex case. She has a large rectus diastasis. And so when it gets that large, it really becomes a functional problem, because if your muscles are not in proper alignment, you cannot support your core. You have back pain. You have difficulty performing daily activities, even just getting out of bed or moving or exercise. It really is a functional problem. The difference, or the other issue, is that we deal with this commonly in the tummy tuck world. And in the tummy tuck world, we see lots of rectus diastasis, and we combine the repair of the rectus diastasis with liposuction and skin removal and a whole body contouring, mommy makeover kind of situation. So people tend to think of that as a more cosmetic procedure and forget that there's a whole functional procedure as well.
Well, let me ask you about that, because I always felt that the rectus diastasis, which is, by the way, not a ventral hernia,
No.
which is a hernia is where that fascia has torn and there's protrusion of either preperitoneal fat or intestines or whatever.
It can become a hernia.
Your spleen, whatever wants to come through there.
If it stretches enough, it can become a hernia.
It can. So once it tears and but functionally speaking, I think they're pretty similar. I think if you have a bad rectus, I've had some rectus diastasis that are 12 centimeters wide. The muscles are
splayed. They're separated.
They're in different counties.
Yeah.
And that's to me is a functional problem, because when you're talking about being able to work your core, that is not going to happen easily.
Yeah, muscles have to be in functional alignment.
They do. And so that's why I always felt, and not to, belabor the insurance point, but insurance won't pay for rectus diastasis repair, even if it is that wide, because it's truly not a ventral hernia.
Right. And I think in some cases, maybe some people you can. I think that was her question because she was seeing doctors at a university setting. And it sounds like insurance was going to cover it, maybe because it was so bad or there were some other
Right, 'cause
things
she
that
had
they had to
functional
do.
problems
She had
from
functional
it.
problems. And so under an insurance, hospital-based situation, these surgeons were going to repair her rectus diastasis. But then she was seeing plastic surgeons out in the community who are saying, yeah, of course we'll fix that, but we can also do all of this for you, and we can make it look better. And so her
course.
question was like, well, what's the difference? And why is the hospital-based surgeon not talking to me about the cosmetics? And why are the private practice guys glossing over the functionality component of it and only talking about how good I'm going to look? And what's the difference? Is it because one is totally insurance based and one is not? Or like, are they two different surgeons? Or like, what is the difference? And so that's sort of what I want to break down.
Well, and we just had our LASPS, the Los Angeles Society of Plastic Surgeons meeting about sort of tummy tuck updates, which I thought was really great. And I thought the discussion was great.
Yeah.
So yeah, I think that in terms of understanding it, it's first of all, for your person who's asked this, surgeons will focus on what they want to focus on because that's their bread and butter. That's where they go to. The hospital-based plastic surgeon has a different focus than the private practice, out in the community, plastic surgeon who is not typically not dealing with insurance companies. So they're not going to be focused on but the truth is that surgeon in the community will be doing your functional surgery as part of their cosmetic. That's right. It's part of the tummy tuck. So it's not that they aren't focused on it. They are. They just aren't articulating it to you that way.
It's a part of everything they're going to offer. So they're like, yeah, I got that. But also look what I can do for you.
Okay, I'll tell you this is a horrible story. I think I need to tell it. And, and I don't want to tell it because it bothers me, because it 100% does. But this will bring it home for those of you who are sitting in the audience and those of you, even the plastic surgeons who are listening. When I was in my residency in Pittsburgh, there was a plastic surgeon that would staple the skin of her breast reduction patients. She would she'd do the reduction. She would close the deep layers with a over and over kind of subcuticular stitch, which is like a deep skin stitch. And then instead of closing the scars nicely she thought it was nice, but she would then staple the skin of the breast rapidly, because that takes minutes,
right?
As opposed to a half hour or an hour. And her argument was, I get paid this much by insurance to do this breast reduction. It's a functional operation. There is no cosmetic component to it according to the insurance company. And so the most rapid way that I can close the skin is with staples.
And you know what? She's not wrong. And this is where it gets horrible. This is where insurance gets really tricky. And we kind of just talked about this on our last podcast. Right. But the same doctor who will spend hours making that breast look so beautiful, and is it the size she wanted? I think she wanted to be a little bit smaller. Okay, let me go back in there and take a little more tissue. Are they symmetric? No, I think that one's a little bit off. Okay, let's go back and take some more. Sit her up, sit her down. Spend so much time making them look beautiful. And then you have the surgeon that stapled it shut, and who cares if they're lopsided? Who cares what they look like?
She did the job.
Both get paid the exact same amount by insurance. So that is where she's not wrong. So that is exactly kind of how insurance-based surgeons think sometimes. And it is, so this is what I was going to tell her. And I don't know the hospital-based system that she's going to. I will talk about what I do in my hospital-based system. But if you were talking solely about repairing a rectus diastasis and you have no concern for the cosmetic outcome of the surgery, you are going to get an incision that goes from your breastbone, the sternum, all the way down to your pubic bone, straight down the center, and they're going to make a big scar right down the center of your abdomen. They're going to go in there. They're going to put the muscles back together. Who cares if there's extra skin? They may or may not take it. They may leave it behind. And then it doesn't matter because they've fixed the problem,
That's right.
which is the separation of the muscles. And I don't know what they're going to do with the skin. I don't know where they're going to place their scar, but it doesn't matter because they've fixed the muscles. Now, if you were to go to someone that you are paying cash to in the community who wants to make you a nice abdomen, they will put an incision in the bikini line area, nice and low where you can hide it. They'll do all the work it takes to get to the top of the breastbone and the sternum to see the muscles from that incision way down by the pubic
That's
bone.
right.
And then they'll repair the muscles. They'll remove the extra skin that's hanging down. They'll build you a nice, pretty belly button, liposuction if you need it, because they are focused, yes, on the functionality, but also on how everything looks, because that is what you are paying them to do. So
That's
that
right.
is at its most fundamental, the difference between a functional abdominal wall repair and an abdominoplasty. Now, in the practice that I have, it's a blend, and a lot of practices will do this. So there are some practices. I have a hospital-based group that I work with that does take insurance. And so if somehow you were able to get the rectus diastasis covered by insurance, then I would say, okay, great. Insurance is going to cover that part of the repair. If you want me to make this look good, then there are going to be separate cosmetic fees. And I'm going to do the pretty incision, and I'm going to do the liposuction. I'm going to give you a pretty belly button, and I'll do all the things that the person in the private practice world would do as well. But you will pay extra for those cosmetic
But
things.
doctor, why can't you just bill the insurance for that?
You can't bill the insurance because they are not billable codes. And this gets really technocratic. But every procedure a surgeon does has what's called a CPT code. So a CPT code for a hernia repair is this, and for a paniculectomy, it's that. And the insurance companies reimburse X amount of dollars. For things like abdominoplasty, liposuction, there are CPT codes. Liposuction is 15877, and abdominoplasty 15847. There
Damn.
are codes, but guess what the reimbursement is from the insurance company for those codes?
No payment to provider.
No payment to providers, zero. So, oh, great, I'm glad you did all that work. Thanks for submitting the paperwork. Here's absolutely
Yeah, we're
nothing
going
to
to give you
you.
nothing. You're welcome.
Yeah. So,
Hey, but great job.
but great job. Kudos to you. So that's where you kind of have to look and see, like, every system's different, every doctor is different, every insurance is different. But at its most basic, that's the difference between a functional abdominal wall repair and a more cosmetic tummy tuck.
So the other part that comes up with this too is like, I have an umbilical hernia. Can you fix it during my abdominoplasty? Oh, won't insurance cover it? And that this gets, so I don't quote unquote take insurance. I'm not an in-network provider. I will help you bill insurance if for some reason there's like a very special need that I can provide. I will make a contract with an insurance company, which I've done for like my cleft nose repairs, things that are sort of far out of the bounds of the other surgeons, that they're just like, I ain't doing this. You can talk to Jay Calvert. Maybe he can fix it for you. So I will make contracts for those cases that are, they're fine. They pay me, and the patients don't have, their insurance gets behind them and backs them up and says, yeah, you know what? This is worth it. We need an expert. We don't have anybody in our network who can do it.
And you tell them their fees, and you ask
And
for
they pay
what
it.
you
Yeah,
need.
and they pay it. The insurers are like, I mean, but like with abdominal wall stuff, like, can you fix the umbilical hernia during a tummy tuck? Of course you can. Is there an extra charge for that? Is there, it's more work, right? It is.
Right.
I mean, it's not,
It's an extra
if
procedure.
we're doing a tummy tuck, we're doing a tummy tuck. If now all of a sudden it's like, oh, and by the way, fix my umbilical hernia. Well, there's 45 minutes more of work to do and more problems to take care of after surgery, which is the part that patients don't think about.
Yeah.
Like the fact that you have to do that umbilical hernia repair, like what if you catch the bowel with a suture?
Yeah.
What if you get, a recurrence of the hernia? What if all those things are things that can come up? And so, yeah, we need to be paid for that. And that's how our abdominal wall kind of, are not only just our reconstructive like kind of ladder of what to do with the abdominal wall, but how are we going to make it look good? Are we going to do liposuction? Are we going to do, the plications that are, designed to make, things tighter? Are we going to do Renuvion with our liposuction? Like, are we going to liposuction the whole abdomen first and then lift the flap and then do these are all things that come up in terms of our planning that, require us to anticipate how to do the operation for this exact patient. Your exact patient has, very specific concerns. And then you want to address those, you want to address those concerns, but you also want to do everything in the most effective and the safest manner possible.
Right. And this is where I do have some patients which get a little bit, usually in my larger bariatric patients, where they're going to have big surgeries, and maybe they have some underlying health
Sister,
issues.
You ain't kidding with your big surgeries. I just want to tell the audience, by the way, like we were in Paris and Dr. Rovelo gives this talk about her BMI limitations, which evidently there are none, in terms of her ability
I was just giving talks on my usual patients.
And I mean, Dan Delvecchio looked like he was just like, oh my God. And the rest of the panel, all these, world experts in body contouring are looking at, Dr. Rovelo up there, this, 100-pound surgeon going up there saying like, and this is what I do on a regular basis. And they were just like, oh my God, like, what? Are you kidding me? And it was pretty incredible. Like the stuff that you showed was off the chain. It was incredible. I mean, and they said that. They said, I don't know how you can do that, but I guess you've busted the limitations of BMI. And your point was that BMI isn't necessarily what you go by. You don't go by BMI. You go by, can you do the operation safely and get great results, which you clearly can. I wouldn't do those cases. I don't think those guys would do those cases, but they saw that it is possible. And so just when people are wondering, like, who's this expert talking to me? That's who I have across the table from me.
And the point of that I think you're bringing up is that, yes, so when you have these big complex patients with multiple medical problems, a complex, long surgery, a lot of times these definitely need to be done in a hospital setting because if you are, and they can be done in the outpatient. They can. But sometimes being in an inpatient setting is a little bit safer to do. And so if you are not working in a hospital group that can accommodate a cosmetic procedure in a hospital, it's tricky. Like I have one hospital literally, as you know, a mile down the street from us here in Beverly Hills. When I try and do my combo procedures there, part insurance, part cosmetic, oh my gosh, I had this one patient and she was going to stay either overnight one night or maybe overnight 2 nights, depending on how she felt. But the majority of it was going to be cosmetic work. She had a small, tiny insurance component to it. But it was going to be a long case, a big case, and maybe 1 or 2 nights of stay in the hospital. For a 23-hour observation stay, the cosmetic fees for her surgery and for her overnight stay were like $90,000. These are not my fees. This is not what Dr. Rovelo is taking home. But wait, there's more.
Oh my God!
If she wanted to stay for 2 nights, 48 hours, it would be $300,000. That's what Cedars-Sinai thought it should be for the procedure. So when you have
how is that even possible?
Don't even know.
What freaking crack pipe is that administrator hitting?
I don't know, because in any other world, it would be a fraction of those fees. So then it becomes, well, this patient needs a surgery. So now we're going to look at breaking it into maybe a couple different smaller surgeries we can do in the outpatient setting. So it's not always easy to get an insurance/cosmetic procedure bundle done in a hospital because there's all these barriers to getting it done.
They just don't want it.
They just don't want it.
They don't want us there.
But that being said, I do have another hospital I go to, which is very reasonable and works with me to get those fees to a reasonable kind of surgery outpatient setting fee. So it just depends on what's available to you.
I mean, that's crazy.
Crazy. I know. My coordinator, Jessica, gave me those quotes, and I was like, I I'm sure she emailed them to the
what
patient and she was like,
in the
what?
what on God's green earth are they talking about for a cosmetic operation?
I don't know.
Like, are they wasted?
I think they just don't want to do the cases.
They just don't want it. They don't want it there.
No.
Hoag Hospital in Newport Beach has done the same thing. Like
Yeah.
they have kicked everybody out. When I was in Pittsburgh, I went back as visiting professor to give lectures there, and I'm talking to the guy that was hired by the Department of Plastic Surgery there to be their cosmetic guy. He did a fellowship, at Cleveland Clinic, and he's great. And he's basically doing like moles and some Mohs reconstruction because he can't get people to sign up for cosmetic surgery because he's hospital based. And this is in Pittsburgh, Pennsylvania. The OR fees, and I may be wrong, I may be off on this, but it was something like $5,000 an hour for the operating room.
Jeez. Which is actually probably the fee they bill to insurance. And then insurance says, yeah, sounds good. Here's $1,000.
Well, you see, this is the part that people don't know about. I'm going to tell you a little insider tip because I was buddies with the COO of one of my hospitals. So they would finish a quarter, and like the hospital, which was a big trauma center, big hospital, they'd be like, Blue Shield owes us $14 million for this quarter. And they would go to Blue Shield and be like, hey, you haven't paid your bill. We need you to pay it. And Blue Shield would be like, well, you know what? We'd like to pay that to you. We see we owe you $14 million. But that's going to take us about 90 days to get it to you. We could probably pay it this week for $11 million, though. If you'd like $11 million, we could send it. And, of course, the hospital would be like, great, we love the $11 million.
Yeah.
Because for them, it's kind of found money, right? Nobody owns that hospital. Nobody has, skin in the game. It's, they're a trauma center. They're getting money from the state and from the federal government to be a hospital anyway. And they're already making their budget. It doesn't even matter. So they're like, sure, we'll take $11 million. So when that happens, I asked this COO very clearly. I said, when that happens, what happens to the EOBs, the explanation of benefits that came in from Blue Shield, that they paid this, they paid that, they paid that? They go, oh, nothing, it just still stays the same, but we just negotiate what money actually changes hands because it was, quote unquote, paid, even though they negotiated
a lower fee.
A lower fee for all that bundled up surgery and outpatient setting and antibiotics they wrote and everything and hospital stays and ICU care and the number of IVs that the nurses ran it. And so then all of a sudden they say, well, we'll take $11 million. And they go, okay, great. But no adjustment shows up to the patients, which is why, when it comes right down to it, you have no clue what's actually happening with your insurance and with your payments.
No clue. It is so gangster. It
is gangster in a big way.
People who have medical degrees in this have a hard time understanding how insurance reimbursement works, and it's so tricky. But it's a game of shells. It's just
Yeah, but so when that question comes up, what's the difference between my abdominal wall reconstruction and a tummy tuck? It's night and day. It is night and day. And again, these things are coming up for us because our listeners are like, but wait a minute. They want to know. They want to get to the bottom of it, and it's very hard.
It's so tricky. Yeah, when you start throwing insurance, this, and our last podcast we did about why do some people charge this much and some it's not an easy world to navigate. I will give that to the patients. It's really hard to understand what exactly you're paying for and why.
Yeah, and I think the best thing that we can do as sort of people that are in this conversation is try to provide the information and the, sort of pull back the curtain and see what's what and just understand it's working against you.
Yeah, and just a quick explanation on EOBs. I don't think I even understood this until I was a practicing physician, submitting bills to insurance companies. When you get your EOB in the mail, it's going to have what your physician or your hospital charged to your insurance provider. And then there's going to be a column that says what they pay. And then there's a column that says what the patient owes. And if you really look at those numbers, you'll see huge discrepancies between them. The hospital or your physician might charge $15,000 for this procedure. And if they are in-network, insurance says, okay, sounds good, we'll pay you $250. And because you are an in-network provider, you are limited in how much you can bill, so the patient only owes $82. And that's how that works. So when you see that $15,000 billed by your provider to your insurance company, that is not what they are getting paid. They are getting paid the $250 or whatever insurance finally reimburses them. And the reason there's such a discrepancy is because that's how the hospitals work. And everyone just follows the hospitals. The hospitals submit these huge balloon sums to the insurance and hope that insurance negotiates down to a lower fee. Oh, we'll give you $11 million. They're like, great, would have taken $3. Like that. And that's why it's so hard for patients to understand exactly what they're seeing on those statements, because it's monopoly money.
Well, the way I always thought about it was billed charges was a measure of work. It's the number of relative base value units, like your RVUs.
Relative value unit.
Relative value units, right. So those RVUs are based on it's set like a skin graft has so much value.
Right.
A breast reduction has this many RVUs.
Right.
And then that's multiplied, like Medicare has then decided, the federal government has decided that that's worth this much money. Like an RVU in Medicare might be $70 per unit. And
Right.
this breast reduction is, 120, units. And
Right.
so it's 60 times 120.
Right.
And then guys like me, when I used to take insurance, I would multiply that by like 7, because that was what I thought my time and effort was worth in order to run my practice. So I would get a billed charge for a breast reduction of $16,000. That is not what I'm going to get paid.
No.
That's the billed charges. So that was a measure of work. That showed what was done and how it was done and what it was worth. And if there were modifiers on it, that measure would go up. So the billed charges were simply work. And then what it's worth would be like, well, Dr. J. Calvert, you are a provider who works with UC Irvine. And I was, this is when I was a UC Irvine, assistant professor. And they'd say, well, because you're there, you're contracted. And we've contracted your services at 0.8 of Medicare charges. So the fact that you billed $16,000 is very nice. Thank you very much.
Good job.
But remember how we said that the RVU is worth $60? Well, with you, it's not.
It's
because
0.8.
Because your institution has said we're willing to take 0.8 of the $60. So yours is actually worth $48. And of that $48, we're also going to get a discount of 70% on your RVUs. So for that breast reduction, you're actually going to get $490.
Yep.
And that, you'd see the billed charges of $16,000, but what got paid was $470. Mm-hmm. And that is a real case that I am telling you about.
1,000%.
That's right. So I would do a breast reduction for $470. Now, if you work at In-N-Out Burger and flip burgers for a couple days, you can make $470 in no time flat, right? You can probably do it in 2 or 3 days. Mm-hmm. But they sort of said, well, it's $470. It's better than working at In-N-Out Burger. I was like, except that I went to school and spent some money and some time and gave my 20s to this. So I just was like, that's not going to work anymore. And that's why I could not work for, the state, because they did not value.
They do not.
What we do.
Not
And that
at all.
so this long discussion is basically to say that when you're looking at the abdominal wall reconstruction in a certain system versus the cosmetic tummy tuck, the operations may or may not look the same, but they're completely and utterly different.
Kind of. Because in one of them, you'll get everything.
Yes. You'll get your operation either way.
Yeah. But they are, and depending on who the surgeons are and how they do their thing, they could be night and day aesthetic results. And that is where the old adage of you get what you pay for, unfortunately, comes into play.
I think we've knocked this one out of the park.
Yeah, we're on a roll. We're gonna get, I think there's like insurance hitmen like across the street because this is 2 podcasts in a row we've called them out, or maybe Cedar Sinai's across the street. I'm not sure, but
Cedar Sinai is very close
literally
by to where
actually
we
is
are.
across the street. But anyways, all being said, again, this was a comment that came in through us. If you have any questions or comments related to plastic surgery topics, we love to talk about them. We love to hear from the listeners and get any feedback on what you might want to listen or talk about. But in the meantime, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.